I am delighted to be here and want to thank the ISN for inviting me to this meeting. My talk this afternoon is about the uric acid and inflammation. Let me start talking about the prevalence of hyperuricemia in different groups of population. According to the epidemiologic studies, the prevalence of hyperuricemia depends on ethnic and social background, which varies from 2 to 35% in general population. And the hyperuricemia is also found in 25 to 40% of untreated hypertension and more than 70% in malignant hypertension. And importantly, and I wanted to tell you about this prevalence of hyperuricemia is approximately doubled during recent 20 years, becoming one of the emerging clinical concerns in modern society. This slide shows the increased the elevated uric acid level is associated with other clinical conditions shown in this slide. And historically, the hyperuricemia is actually regarded as a consequence of these clinical conditions, or just the simple associations with these other the risk factors of cardiovascular, the risk factor, instead of the etiology of this disease. To explore the role of uric acid as a cause of human disease, we made the animal model of hyperuricemia. I think it was maybe 15 years ago. And to raise the uric acid level, just mild elevation, like a 1.2 to 2-fold higher than the natural level, the rats actually developed hypertension in the microvascular remodeling. And there is some evidence of induction of oxidative stress and the decreased nitric oxide production. And we can also see the vascular and renal inflammation with the activation of renin-angiotensin system. And the rat actually developed kidney disease and showed some evidence of insulin resistance. And very interestingly, all of these findings could be alleviated by uric acid lowering therapy, including xanthine oxidase inhibitor or uricosuric agent. There is some clinical evidence for the association of uric acid and other diseases. And an elevation of uric acid is reported to predict the development of hypertension. And the lowering uric acid results in a decrease in blood pressure. And the elevated uric acid is also associated with congestive heart failure. And the serum uric acid is a risk factor for progression of renal disease in CKD patients, and allopurinol improved renal and cardiovascular survival in CKD patients. And the uric acid was also a predictor of development of diabetic nephropathy, and allopurinol decreased the proteinuria in type 2 diabetes. But I think all of this clinical association, based on previous publication, does not necessarily mean the uric acid play any role in the development of this disease. Many of these clinical studies are observational one, and it is not controlled performed in a very small number of patients. So I think it is a matter of which comes first, like the chicken or the egg. And actually, we wanted to go further about the mechanism of uric acid associated or uric acid related disease. And we have been interested what is the earliest phenomenon, or what is the earliest happening observed in cells or organs in hyperuricemic environment. Back to this, the rat data. This time I marked the timing we observed each findings. As you can see here, the vascular and the renal inflammation is one of the earliest happening in these animal models. And the vascular and renal inflammation was evident in 1 or 2 weeks after the development of hyperuricemia. This is actually the slide from our rat, and you can easily recognize this is the rat administered oxalic acid, which is a uricase inhibitor. That's the way we make the hyperuricemia. And you can see the anispecific pathologic changes in the kidney, but you can recognize there is some tubular interstitial and glomerular inflammatory cell infiltration. You can also recognize there is ED1 positive brown-stained macrophage infiltrations around the blood vessel and the vascular smooth muscle cell area. There is also some clinical study showing the association between uric acid and other markers of inflammation. This is the result from the Italian cohort, which includes approximately 1,000 subjects without the significant kidney disease. As you can see here, the uric acid concentration was actually correlated very well with the WBC count and the CRP concentration and the markers of pro-inflammatory cytokines. So, today I'm going to tell you about some evidences of uric acid-induced inflammation in vascular and the renal cells. And also I want to spare some time to show the data about the inflammation as a mediator of vascular and metabolic disease. I'm happy to show this slide because we are not the only one to show the uric acid inflammation in the kidney. As you can see, with the administration of oxalic acid, this group actually found the interstitial inflammatory cell infiltration shown here with the association of the upregulation of RANTES and MCP1 and the TNF-alpha. In vitro study, if we transfect the uracil, and it actually commit the uric acid and that more, you can see the RANTES expression. And if we made the gene silencing with the siRNA in the urine, we can actually see that there is a decrease in RANTES and MCP1 TNF-alpha. That means that the uric acid entering into cells may be responsible for the development of this inflammatory reaction. So this is the data from our group, and the uric acid percent actually they increase the CRP expression and the cellular cells, as well as the vascular smooth muscle cell. And the TED also probenecid, it is a real the co-treatment uric acid with the probenecid, there is a down-regulation of CRP expression, again suggesting the uric acid per se inside of the cell can induce inflammation in these human vascular cells. Not only inducing inflammation, uric acid also accelerates the inflammatory reaction shown here. And this is the chemically induced inflammatory model in the liver tissue. When you administer the uric acid, actually this inflammation is more severe. And the transfection of uricase, this is a secretory uricase and intracellular uricase treatment that alleviate the increased inflammatory reaction in the liver. So we now understand uric acid-induced inflammation may do something in the various tissues, including kidney and blood vessel. I'm going to tell you about the inflammation as a mediator of vascular and metabolic disease. Inflammation is a cytosolic multiprotein complex, which is now regarded as vital for the inflammatory response. And the inflammation consists of the molecules shown here. One is the NLRP. It is an node-like intracytoplasmic receptor protein. And the ASC. ASC is an apoptotic spike protein. It is actually the recruitment of caspase. And if cell is exposed to specific signal or stimuli, there is increased transcription of these components, NLRP, ASC, and procaspase-1. And the second heat signal actually enhances the assembly of these components and make a kind of intracytoplasmic structure called as inflammation. And after making this inflammation, it activates caspase and activates IL-1 beta or IL-18 release. And the NLRP3 inflammation is one of the most well-characterized inflammation to induce the various human diseases. This is the data about the role of NLRP3 inflammation in patients with type 2 diabetes. As you can see here, compared to healthy control, newly diagnosed type 2 diabetic patients, IL-1 beta and NLRP3 and ASC the expression was increased both in constitutional level and LPS-induced. When they treated the diabetic patient with metformin for 2 months, and the macrophage isolated from the patient, you can actually see there decreased the test page 1 IL-1 beta, the expression. It is a quantitation graph. Inflammasome is also regarded as a mediator of atherosclerosis. You can see it. And the cholesterol crystal induced the expression of the caspase-1 shown here is significantly ameliorated in NLRP3 and ASSD knockout mouse. And you can see there is a much decrease in the expression of IL-1 beta in NLRP3 and ASSD knockout mouse. This is this slide showing the pathology. You can recognize there is much improved atherosclerotic lesion. It is a Ginza staining the aortic sinus, and compared to control in the NLRP3 and the ASSD knockout mouse, there is a decreased atherosclerotic lesion. And again, this NLRP3 mediated inflammation may play a role in the development of vascular disease too. I'm going to talk about the lessons from uric acid crystal-induced inflammation in gout because there is some lessons from this the data. We all know the gout is an inflammatory disease induced by monosodium urate. And monosodium urate injection actually increased the neutrophil influx shown here, and the treatment with the uricase decreased the monosodium urate, increased the neutrophil influx. And this monosodium urate, the crystal, is actually first one to induce the NLRP3 inflammation, the activation. You can see here, monosodium urate crystal increased the neutrophil influx is much decreased in caspase knockout and ASSD knockout mouse. And there are many papers, monosodium urate crystal induced inflammation activation. Actually, the monosodium urate is used as a positive control in the inflammation-related experiment. You can see here, this is not the macrophage and not the kidney. This is the data about the lung inflammation induced by bleomycin. And very interestingly, bleomycin induced a lung injury and increased the IL-1 beta production, and the TIMP-1 production was ameliorated by allopurinol, suggesting uric acid to play some role in the development of bleomycin-induced inflammation or the fibrosis. You can recognize there is uric acid crystal in alveolar macrophage, and uric acid crystal induced the cell, the inflammatory cell infiltration in bile fluid in a dose-dependent manner. But what's the role of inflammation as the mediator of kidney disease? And the uric acid is kidney disease. We now know it is not crystal dependent. We know monosodium urate crystal induced inflammation via the inflammation and NLRP3 inflammation mediated pathway. But the kidney disease actually is not related to the crystal. We have published the many data set. It is nothing related to the crystal. But there is some paper about the role of NLRP3 inflammation in the development of renal fibrosis here. And this is the animal data from UUO model, is a representative model of renal fibrosis. As you can see, in the NLRP knockout mouse, there is a substantial decrease in tubular dilatation and the interstitial fibrosis and the cell infiltration shown here. Again, this NLRP3 inflammation may play a role in the development of renal fibrosis, even if it is not related to crystal. In the clinical data, and NLRP3 mRNA expression in the kidney biopsy specimens with various of chronic GN, APN, and hypertensive nephrosclerosis was very increased compared to control. And very interestingly, there is the positive correlation between baseline creatinine concentration and the renal NLRP3 the expression. So even without the crystal, and there is the role of NLRP3 inflammation. Our group published the data about the uric acid induced phenotype transition of renal tubular cells. As you can see, this is the NRK cells, the control cells, compared to control cells, uric acid exposure induced the phenotype transition, so-called endocellular to epithelial to mesenchymal transition, EMT. This is the in vitro data. This is the animal data. And you can see the decreased macro and epithelial cell macro expression with the increase in alpha smooth muscle, which is ameliorated with allopurinol treatment. What we found interesting was when we expose the NRK cells uric acid, there is a significant increase in NLRP3 and ASSD expression. So with that data, what we have done was to see the effect of gene silence over NLRP3 and ASSD, to see the effect of the involvement of this inflammation-mediated pathway is uric acid-induced non-crystal dependent renal damage. As you can see, uric acid-induced EMT was pretty much ameliorated by gene silence over NLRP3 and ASSD. Several days ago, the Kim and Moon from Kyung University, they showed me a very interesting data. I will show this data with getting their permission. And they want to see the effect of inflammation in a hyperuricemic diabetic model. And they actually made a diabetic model in a OLEC lab. And they fed the rat with a high fructose diet. And the uric acid level is almost 3 times higher in OLEC with a high fructose diet. And you can see that the glomerular hypertrophy and the tubular damage scale was pretty much increased in this hyperuricemic, the diabetic rat, and which was significantly ameliorated with allopurinol treatment shown here. And it's very interesting. This OLEC high fructose diet rat, there is an increase in NLRP3 and the ASSD, and you can see the activated caspase band here, and which were all ameliorated with allopurinol treatment. And the tissue, kidney renal tissue iron or beta concentration was significantly increased, which was also alleviated with allopurinol. OLEC rat, also there is some increase in IL-1 level. You can see that there is an inflammatory cell situation in this hyperuricemic diabetic animal models, and they ameliorated with allopurinol treatment. So we now know that the hyperuricemia induced renal inflammation and fibrosis, maybe partially with the NLRP3 inflammation-mediated pathway. To summarize my talk, the vascular and renal inflammation is one of the earliest phenomena in hyperuricemia. The NLRP3 inflammation activation is an important pathway of vascular, metabolic, and renal disease. And uric acid crystal-induced inflammation by an NLRP3 inflammation-dependent pathway. And the uric acid also induced renal fibrosis and phenotype cell transition by a crystal-independent NLRP3 inflammation activation, provide a novel mechanism of uric acid-induced renal damage. This is the last and most important slide of my work was done by my students and the fellows in my lab in Ewha, and I also thank the wonderful collaboration with the Sookmyung University. Thank you for your attention.